So I'm going to start very slowly and introduce the background and domain in which Genome One is being active. And I'm going to start with basically the fact that in the same way in which we're coding applications that end up on the web or our mobile devices, there is this thing called our genetic code that creates a human app, right? So everything we have and everything that defines us, in particular from a physical, but also I guess also from a psychological perspective, lies in the code that is being written in our genes. And you can see here, the pairs of the chromosomes that we have, and the way in which the chromosomes, the alignment of the chromosomes, and how the genes are being defined when we're born, affects the way we're looking, for example, and also to a large extent the way we're behaving. I guess more importantly, the genome and the DNA affects our health, and we take this very seriously. Obviously, there is there's an aspect related to the inheritance and the way in which DNA is passed on from, and our genes are passed on from generation to generation. It has a tremendous impact on how we age and how our health evolves in time, and also lately, and as it has been discovered, it influences a lot, for example, the way we're reacting to various viruses, bacteria, as well as to the various medication that is being used in current practice. Now, this is particularly important because we're getting to the point where genomes, and by genomes, just to make it clear, I refer to, I guess, that product of our DNA being sort of decoded in that long sort of string of 4 letters. So genomes are really coming to age, and they're becoming slowly a commodity. And here you can see the amount of funds that have been invested in the last about 5 years. So we're really talking about, I guess, the last 5 years in genome sequencing and genome related technology. And you can see that obviously the US is out there with over, and the US and Canada is out there with over $10 billion. Europe, is in the 600 million euros, and then the UK with the 100,000 Genomes project in the 310 million pounds. And Australia and in general the APAC region is trying to follow as well. In Australia, we had several programs, both at the federal level as well as at the local state level, where there were several rounds of about $25 million put into basically using genomic technology and genomes in general, and bringing them into clinical care, and trying to understand how they can both assist with diagnosis of diseases, but also getting closer and closer to using them for prevention and for health management. Now, one interesting aspect with respect to the genomes, and this is, I guess, where it really this is why we're saying that they are actually coming and they're more or less there, is this evolution of the cost of sequencing the genome. And you can see here that it kind of dropped fairly abruptly, I would say, from about $100 million, that was more or less the cost of the first genome being sequenced, or the whole genome being sequenced in 2001, to today at about $850. So there's really a dramatic decrease in the cost of the genome, and as I said, it kind of at this point it kind of becomes more of a commodity, and the shift has we're assisting, basically we're witnessing a shift from understanding how the sequencing process works into really optimizing, for example, the alignment to a reference genome, parallelizing the process, making it faster, cheaper, but also really shifting towards understanding what is really in the genome that we can use for health management and prevention. So what exactly does Genome.1 do? We're really trying to combine whole genome, so basically understanding the decoding of the DNA and using the entire genome together with the clinical characteristic to get to an interpretation of the genome in context, again, because the clinical characteristics would be particular to a specific patient or to a specific individual, and interpreting those characteristics so interpreting the genome in the context of those clinical characteristics to get to a genetic answer. And at that point, the genetic answer could help either to diagnose a patient or to really look into the predisposition of a certain individual to a certain disorder, to understand exactly how in general the health management or how the health in general can be used, so it can be managed by means of the underlying or underpinning genomic information. Now, the genome again has a tremendous impact over the entire span of healthcare, and you can see here that in reality it really goes from the very beginning, as in before we were born, in the carrier screening phase, where couples that want to conceive, they would in principle, or they could in principle, have a genetic test. Especially if there are certain concerns with respect to certain diseases that have been diagnosed in the family. So it's really before we're born at the very end, when we die, and again the genome can be used for understanding, for example, the death cases. Now, as you can see here, this is really quite a varied set of tasks that have or can use genome for interpretation and for basically for decision making. Now, in Genome 1 in particular has been active so far in the rare disease diagnosis space. We were the first Australian company to be accredited for clinical diagnosis using whole genome sequencing, and that was again in the rare disease space. But we're now going more towards not diagnosis, but towards really prevention and understanding. For example, how can we use the genome to dose or how can we use the genome, for example, to understand what is the effect of a certain medication over a patient, or to what extent that particular patient or individual may have side effects, obviously unwanted side effects from a certain medication. So it's really about getting towards prevention and health management. So we were also among, I guess, the first companies that put out there, again, in this precision healthcare space, a product that takes the genome, again, the 6 billionth of characters of the DNA that is sequenced, and really churns it through a bioinformatics pipeline and then from a genomic interpretation process, and trying to look at things like, for example, cancer predisposition, and you can see here the number of genes that we're looking at, other genes that are related to cardiovascular conditions, but also to medications, and understanding, to what extent, or what is the relationship between certain mutations that you may have in your genome and medication that you may be prescribed. Now, genetic testing in general in healthcare, and I guess what I'm trying to do now is going back to the idea of we have the whole genome, but what we're really trying to do is really making it available as part of the clinical care, because to a large extent so far, especially when it comes to whole genome rather than just genetic testing, which could take various other kind of forms, a lot simpler than doing a sequencing of the entire genome. Genetic testing using whole genome sequencing is really cumbersome. So you can see here in the entire path, it goes from a referral to a consultation with specialist. There's obviously counseling is a very important aspect, because it's really about understanding not only the intended outcome of the report, the report that will be produced at the end of the genome interpretation, but also the impact that that information has on the entire family, right? So keeping in mind that we're not talking only about you as an individual, but we're also talking about perhaps things that may affect your children later on, or things that you may understand why they appear in your case based on your family history. So counseling is a very important step in this process. And then it goes to specimen collection, which then is, blood is then transformed into DNA. DNA is being sequenced, and there's a fairly large analytical task there, that the bioinformatics aspect that transforms the genome, which is in the order of hundreds of gigs of data, into a form that is ready for analysis and for interpretation by clinicians, which is basically the interpretation and reporting step, and then going back to the consultation with the specialist. Again, counseling. Once we know the result, obviously it's very important to understand what exactly does that result mean in general for the individual, also from a family perspective, and then back to the specialist and some clinical action. So you can see there's quite a number of steps, and in general, this particular workflow takes about, in the best case scenario, takes about 12 weeks. So what we're trying to do is really making sure that the genomes really are part of our health record, and they're there to assist and get us to a clinical action in basically in no time rather than in 12 weeks. So the way we're trying to get to this point is basically to do genome basically sequencing once, and then do in the reinterpretation or querying of the genome in context, given a certain event, which obviously event is related to symptoms that you may exhibit several times, right? So basically, from what we're trying to do is break this long 12 to 18 weeks workflow into two steps. One, the actual sequencing aspect, which is just about the counseling, because it's very important to understand the information that will come out of the interpretation later on, the specimen collection and stuff, having a genome record to be part of your general health record, and then when it comes to certain events or episodes in your health life, it's really just about point of care interpretation and reporting. So rather than going through this long workflow where interpretation happens only once, and then there's only a single clinical action at the end of the workflow, what we're talking about is really routine decision making at the point of care using the genome record. So you can see here there's these 4 steps where you would go back to the specialist or to a GP. There will be a point of care interpretation, again, because the genome is already there. It's part of your record, together with your with the context provided by that particular episode, and immediately to clinical action and post counseling, and this happening on a sort of routine basis. Now, this is in principle to a large extent what we're aiming to do, and we're very close. We're very close, in particular in Australia, to having this workflow implemented as part of point of care, and what we're trying to basically coin as the point of care genomics. So I think it's worth at this point to go into the technical aspects to see exactly how we're implementing this. And it's worth mentioning that I'm going to focus on the application side of things. As you can see here, there are various steps that have, I guess, other technical tasks involved. And in particular, I guess that the one that is really important is resource intensive is the bioinformatics analysis. So I'm not going to focus on that. I'm going to focus on the idea that you have the genome and you have the symptomatology or the episode, and and we're building applications. And in terms of applications, we were going beyond this point of care implementation. We're also working with various stakeholders on, for example, enabling patients and engaging patients into augmenting their health profile. Again, keeping in mind that if it's not already there, the genome will be there eventually, part of the health record, and an incremental or longitudinal augmentation of the phenotype, in general, of the phenotype, what we call a phenotype profile, or of the symptomatology of the individual, will be beneficial over the long term, because it will really help to understand to what extent the individual is predisposed to a certain disorder, or how certain things can be treated or managed in time. So I'm going to go deep dive into our technical stack. But before doing that, before going into technical step, one aspect that is particularly or is particular to our domain, and I guess it's really what really makes this domain really exciting and fascinating is the fact that at this point in time, and in general with the evolution of science, we have a certain sort of view over what genome can do for health management or for diagnosis. So here you can see an example of an episode where a particular individual is being consulted by a doctor. We can see the symptomatology of the patient, and then using the entire information that we have around the patient, things like, for example, the family history, the genome, but also, and I guess this is a really important aspect, the relationship between the various aspects around the patient, and having them tapped into the existing body of knowledge around the genome and around the symptomatology, which at the end of the day, it turns out to be basically just a large graph. You can end up with the diagnosis. And again, going back to what really makes this field particularly fascinating is that 1 year later, because science evolves and more things are discovered about the genome, or we gain a better and a more deeper understanding of what the genome does, you can immediately action against previous episodes, and you can see here, if for example in 2017 we had that particular diagnosis for this patient, in 2018, because our knowledge has evolved around the genome, and because science and medical care has evolved, we can immediately infer if there is for example, a drug that is available for diagnosis, and automatically, without the need for reconsultation, we can propose, or we can trigger an alert or an event that would go back to the clinician and to the patient, and would lead immediately to clinical action. So again, it's not, I guess, we're looking into a non-static view over the health data or health information around the patient. We're really looking at the health data from a genomic perspective, where the knowledge around the genome evolves, and we always have to be tapped into the existing body of knowledge to be able to drive clinical decision making. So now going back to how we're implementing, or how we're actually making things work, I'm going to talk about the technical stack. So we are, to a large extent, a Java house, if I may say so. So you can see here our technical stack. We basically we're using a microservice-oriented architecture, built on top of Java and Spring 2.0, and using MongoDB as a database engine. And on the front end, predominantly sort of React and Redux. Now, in terms of architecture, as I mentioned, where we have adopted the microservice-oriented architecture because it really allows us to create that, I guess, the business sort of context for each of the pieces of code that we have to produce, and it really allows us to sort of, to impose an individual life cycle for each of the microservices, and at the application level, it allows us to have an expanded portfolio of applications that are really domain oriented, such as, for example, the patient engagement platform, or a clinician-facing decision-making platform, whether web one or one that is being integrated directly into the point of care. So basically, this is basically the architecture, using the standards for microservices with the gateways to be able to do a proper separation of concerns, and then applications that are domain oriented at the top. And on the left side, you can see that we're using Kafka for messaging purposes. Now, in terms of deployment, the architecture is being deployed in a Kubernetes cluster, because really it allows us to auto scale, and we can immediately tap into the properties of a Kube cluster, such as self-healing or the fault tolerance, and in addition to this, we at least at this point, we're using the standard ELK stack for monitoring logs. Now, just a bit about security. Obviously, we're taking the security, and data privacy very, very seriously, and I guess beyond the standard and expected communication over HTTPS. We've introduced access control and authentication at every single layer of communication within the platform. So obviously you have the the security provided by the within the Docker containers, but then the communication, for example, between several containers or between several microservices done via an authentication layer, and via access control, and we have very clearly defined rules with respect to what microservice, for example, can access the endpoints or the API provided by another microservice, and in this way, really trying to minimize the risk of external factors being able to tamper with the data that is being managed by a particular microservice. Now, in terms of the build process, I guess this is where we're getting back to the point mentioned by Mark. So we're using the standard Keyflow development approach, and GitHub and ZenHub to manage our agile development process. Now, once we have, I guess, a particular change and within the code base, the build plans are being then managed and using Atlassian, and this is, I guess, where Nexus and Nexus IQ become really critical as part of our build process, both for managing the artifacts that are the outcomes basically of the build process, but in particular really to manage our the dependencies, the vulnerabilities around dependencies and the license check. I'll go back into this in a second, but just to go back to the general build process, code based is being built using Bamboo, is obviously being checked for vulnerabilities using Nexus IQ as part of the build plan. Then we're going through an application security testing, the testing phase, and finally, once the new build is there, the build is Dockerized again using Bamboo, and then is being automatically deployed. Depending on the context, either in AWS or in GCP. I'm saying depending on the context because we're running several environments, both so production as well as development environments in both in AWS as well as in GCP. And I guess this pipeline really enables us to be fairly independent and fairly transparent with respect to the deployment process, and it doesn't necessarily affect us or it doesn't necessarily have an impact the fact that we're using multiple cloud providers. So going back to the role that the Sonatype products have in our build plan, we really see them as being sort of a critical components within this process. In particular, when it comes to the vulnerability verification and the update management of each of the components, and we've talked with Mark about this, how important and how easy this process has become now that we're using Nexus IQ versus how we used to do things before we've engaged Sonatype, and how to a large extent we were blinded to the vulnerabilities that the dependencies that we have, and how we were not really able to manage them appropriately. Having Nexus IQ as part of the process really lifts a lot of the weight off our shoulders, and it is practically embedded within the build plan, and enables us without any effort to keep track and to be always up to date with critical updates to our dependencies, but also to basically immediately take action and to change or to do an update if necessary, both if a vulnerability is being detected, or if one of the dependencies that we have has a license change. That being obviously also particularly important from both business as well as legal perspective. Now, in addition to IQ, which again has made a tremendous impact in our development process, and we're also using a Nexus as an artifact repository for basically all the builds that are or basically the artifacts that are being produced by our products. So that's in principle it. What I really try to do is really take you through again the context, which is getting to use the information that we have in the genome as part of the clinical care, and using it contextualized and in a routine manner, rather than the way it has been used so far within that 12 to 18 weeks workflow. And how important this will become in the future to drive decision making around our health. I've mentioned the applications that we're building using the genome and the symptomatology of the patient, both in terms of engaging patients to augment their health profile, and then to help later on with their health management, as well as the clinical facing aspects that enable the clinicians to take decisions and actions immediately on the combined genomic information as well as the episodic information. I've talked briefly about our technical stack and the microservices oriented architecture, and finally here in the build process, which is to a large extent fairly standard these days. I've really emphasized the role that in particular Nexus IQ has in our process with respect to making sure that we are covered for both vulnerabilities, for the dependencies that we're using, as well as in terms of the legal aspects of the licenses associated with these dependencies. And with this, I would like to thank you and hand it over back to you, Mark.
Thank you, Tudor. Very informative. I've always been fascinated by the work that your team is doing.